Irish program, and we are going to discuss about internship opportunities abroad after that. So welcome to the page in Euronet Assembly.
Good. Um, okay. Okay, I'm going to do a short presentation of what the public health training looks like in Croatia. I'm quite fresh in the residency program, started at the beginning of summer, basically, but I was involved in public health projects and things before when I was something else. So, yeah, we'll start. First, I think I did a short okay, so my name is Ahmed, as I forgot to say, but I've met most of you yesterday, and this is quite popular to say the question. And I'm doing it shortly for Croatia. Well, I found out that most of you were in Croatia already, which is nice, and maybe we'll come back again, and maybe some Euronet arrangements, so we'll see. So Croatia, the touristic slogan for, I think it's obsolete now, but for a while it was a small country for a great holiday. And yeah, I could agree with that. I don't know, not sure if I would endorse it for living there, but for a holiday it's a great country. And it's a small country, so it's about 4 million people, 1,246 islands, and as an independent country, it's quite young, so it's 25 years old, since 1991. This is like some fun fact. What are the common immigration inventions? One that the office red gloves with a tie, some kind of military attire in war, I don't know. Second one is parachute by this engineer artist Paul Francis. And the third one, my favorite, is SMS party. And they mentioned that in some brochures on Croatia, like they're breaking SMS party was mentioned in Croatia. Okay, so I'm going to talk shortly about what the public health training looks like in Croatia. Through 4Cs is the acronym I invented the other day. So what are the components of the residency program? What are the competences that we acquire or are supposed to acquire? Some of the cons and pros, so I inverted these to have the 4Cs. And the comparison to other public health residency programs of the Euronet countries. The residency lasts for 48 months, so 4 years. There are 7 of us currently, and you can see all of the names here. Some of you know Vesna, I think. She was the one who was dealing like Euronet so far. Maya, Ivana, Iva, Željka, Dubravka, and me. So for the residency program, I sometimes feel like this. With all the ladies, right? And there are a total of 25 public health specialists in Croatia, plus 18 specialists in what used to be called social medicine. This is like a predecessor of public health in Croatia. And since 2011, the program has been harmonized with the EU-MS standards, or European Union standards for specializations in medicine. Again, but public health is not the only, and this is something that I wanted to also discuss maybe in the afternoon sessions. We also have a specialization or residency in epidemiology, which there is a bit more people in it, so 26 current residents and 168 specialists. So this is, as I said, a question to see whether we should also include this group. But the residency programs are quite similar. They last for the same 4 years, and yeah, so we'll talk about it. After that, there is another preventive specialization or residency, and that's called school and adolescent medicine. And in the last 10 years, it's been transformed slowly from a curative to a preventive. and there's also around 160 field in Croatia. So the components of the residency program are, in terms of duration, 29 months that we do in the healthcare institutions, kind of clinical work, not 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 really clinical as in clinical residency, but some work with patients and patient groups, and organizational skills, management and organization skills in healthcare institutions. Then there's 5 months in so-called other institutions related to public health ministry, state insurance fund, and there's a scientific project that we do as part of the residency, and 10 months of so-called practical experience in the base institution. So we do our residency for like this so-called formal phase institution. In public health, it's mostly public health institute, the state one, or regional ones. And I think out of the 7 residents, five are doing it for the state public health institute, and 2 of them are doing it for the insurance fund, for the state insurance fund, which is probably relative situation. Another 3 months, we have a specialized graduate study in public health, which is equivalent to MPH, which is what Westland was convincing me into. I'm not really sure. And there's 4 weeks, 4 months of vacation. Talking about competences that are described in the program and that we are supposed to acquire during the residency, they are divided into general and specific ones, like for all residency programs, the general ones include communication, ethics, teamwork, evidence-based medicine, and specific go into these fields, so disease prevention, health promotion, health assessment, commercial health assessment, organization and quality of healthcare system, health policy development and implementation, and planning and management, strategic planning and management in healthcare. So pretty much similar to other public health programs. And we also have a mentor, or we have 2 mentors. We have a so-called main mentor, which we don't see so often, and we have a mentor, which is really the person that you're working with, and you can learn a lot of nice things from your mentor. So this is a quote from my mentor, because we do some European projects, so I travel a lot with soldiers. We were never late for a plane, and we just spend too much time at the airport. Okay, some cons and pros of residency program in Croatia, as we pointed out. So it is a cohesive group because there's not a lot of us in the again. There's not a lot of us, so we are kind of connected, and there are quite strong ties with other Balkan and actually Bavia states in public health. There are some specific competencies that we have acquired due to the situation, so in terms of war medicine, natural disasters, PTSD management, and stuff like that, but kind of regional specific, and deeply rooted, let's say, public health tradition, starting with Andrija Štampar. I don't know if you're familiar with this guy. He was one of the founders of the World Health Organization, and in the 1910 and 1920s, he really transformed the whole preventive medicine in Croatia. I would recommend, I can also offer some reading in English on this guy. He's really great with the whole public health tradition somehow. This is a good thing. The bad thing is that we are dependent on the base institution that we are doing our residency for, so you really do a lot of work for your base institution, and most of the residents are signing a contract that after the residency they need to stay for additional 4 years in the base institution to work there, so kind of tied to it. The second one is for the limited knowledge pool, which arises basically from small communities, public health professionals. So there are some areas of, for instance, organizational quality issues in healthcare, which we are not really able to learn that well in the Croatian setting. So this is, let's say, our motivation to network with Euronet and with all of you to see how we can benefit from you and what we can benefit from us. So, and in terms of doing the residency, lack of awareness go to a lot of clinical institutions, clinical healthcare institutions, so we get the question of what exactly is that you're doing and what are we supposed to do in the community, like internal medicine. But we are fighting. We are fighting. It's not fun. This is the guy, so Andreas Stampad, one of the founders of the show, and there's a nice writing also like in these 10 principles of public health of the 2020s. One of them is that he said it's more important to educate people than to pass. For the comparison, so I used your table that we did for Euronet countries and for Croatia. So as I said, residency, public health residency is less than 4 years. It's only for medical students. MPH, the program that we have like 3 months, is included, 7 residents. Internship abroad is not formally part of the program, and we're not sure whether it's allowed, but definitely it's negotiable, and I think most of the mental institutions will be more than ready to let basically residents go abroad for a while. So the clinical practice is in a restricted form included. It's not a popular choice, not rather at all, and it's in most of the countries. And where we do the training, so mostly in public health institutes, regional units, research institutions, state agencies, Ministry of Health Insurance Fund. And so the hospital-based placement is maybe more pertaining to where we work at. Yes, it's not we don't really have public health professionals. Yeah, I think that's it. So this is our Euronet branch is part of the Creation Society for Public Health. We always have our materials. This is the contact email, and that's what I thank you. Questions? Yeah, okay, the question is how is the 3-month special graduate program equivalent to MPH? She told me that she did it last year, I think, and she told me that she would. So we do a scientific project at the end of that, and it's 3 months full time doing it at school, school of public health, part of the Zagreb School of Medicine, and there is, as I said, like thesis at the end of scientific project. She told me that it will, so not sure. You awarded something that's called the specialist master. I need to check that. How is this in line with maybe a question for you about the military residence. I don't know. What do you think about this?
It's very interesting how it's divided in Croatia, the residency, in public health residents, epidemiology residents, and also to more academic residents. In France, we have always in the public health residents. So, from my point of view, definitely it corresponds to the same idea and to the same spirit of Euronet. That it has to come in a form, in a national form. So if you can organize something with them, and afterwards this association will be a part of Euronet. Yeah, but yeah, definitely. I don't know if you can tell us how stuff is organized. In your case, the epidemiology is included in the public health residency. Okay.
Yeah, definitely. I mean, we were discussing it. It's full public health, and there's not a lot of us, but we are motivated and enthusiastic and willing to work on projects. Hopefully, so. Thanks.
Could you check if the sound changing from your back? Yeah. Could you try here? And yeah.
Put the keyboard closer. Maybe turn the screen.
So, yeah, my name is Fiona, and I'm presenting our training in Ireland. I've been racking my brain trying to think of what was invented. I just all say Guinness. That's all I've got. I'm sure Eden has more things, more examples. I just thought at breakfast today, I was speaking to someone from Portugal, and I haven't included it in my presentation, but our universities or our undergraduate degree, I think it's quite different even than European countries or continental countries like that. We have to pass 6 years, and we have to pass all the exams each year before we can go ahead. So we were shocked to hear that you can carry on and actually consider maybe a year in some of the continental countries. So we get 2 shots at the exams, and if you fail 2 shots, you have to repeat the whole year. And if you fail that year, you're out. So anyway, that is it. So to get on with the CAL training scheme, so just to say that traditionally it hasn't been very popular either in Ireland, but it's had a revival in the last few years, so it's become actually quite competitive. Competitive because we're small numbers, so we've only about 21 of us this year. So, and like last year there was only 13 of us, so we've significantly increased from last year, and we hope to get 81 next year. But to get in, obviously we all have to be medics, so there's no pass for non-medics. We have to do, after the 6 years of university, we have to do 1 year of internship in hospitals. We're not really allowed to come out as part of our internship yet. Then after that, we have to do a basic training, and it can be in any specialty, so medical, surgical, obstetrics, and a lot of us are GPs. There's a couple of surgeons, there's pediatricians, and now there's pediatricians and psychiatrists. But we have to do further training and do all the basic exams that come with it in the specialty. And then once we do that, we get a very long application form, and we do a very scary final with lots of public health centers all sitting in rows staring at you. So that's fun. So yeah, so then we get on the scheme. So some of us will have done the masters beforehand, the MPH, and if you haven't, you have to do it in the first year. But we kind of do it as we work if you do it in the first year. So it's usually the way they arrange the masters, it's conducive for us to work Monday, Tuesday, and then do masters Wednesday, Thursday, Friday. I was looking at doing it before, but I believe it's quite an intense year because we're working and doing full-time masters. So our training scheme is 4 years long. So as I said, the first year we have to do the MPH. You can take an out program experience for 1 year, and this can be clinical and research. The amount of time that they can have part of your training depends on case by case, really. You have to kind of prove that it is relevant to something on training for the most closer 4 years. And so if you want to do a PhD, you can do a PhD in 3 years, and 1 year of that can count in the training. And then each year, so it seems to us that here on the continental side, you guys do a lot of kind of teaching and talk about professors and you're affiliated to colleges, whereas here in Ireland, it's a national program. We have 1 college or college positions, and you come in on your lot. But we don't do any classes, and we don't really have we change trainer each year, but it's not a formal kind of, didactic lecture system. We do have, I think, 6 to 8 studies each year where all of us get together and we unfortunately often go to Dublin, and we pick what the study day is about, and we have quite influence on what we want the study days to be about. So then for our assessments, we have 2 exams. One is a written exam that we have to do in the first year. And then the part 2 is an oral exam, and then we have to write 3 big long reports and get oral exams on those reports, and we have to defend them. As well, we do have the competencies that you spoke of are going to look because they keep changing, and so we're in the process of finding what our current ones are. But we get a lot more on each 3 months, and then each 6 months, our trainer grades us on our competencies and how we've achieved them, and we have to kind of try and sell how our work fits the competencies. And we keep a logbook to that end, and then we have an annual review of the actual training and then external, and decide whether we're allowed to go on next year or if there's areas that we have to improve on. I was asking about the MBH options. We have the main one up to recently was in Dublin, UCD, University College Dublin, and you do it full time as I described in 1 year, or you could do it part time over 2 years. But recently, I don't know how recent the court in the south of Ireland, there's a new master's program. I don't know how new the one where you attend is, but it's a new online, it's completely online and taught through English. So that you don't have to come to court to do your exams. So there's a lot of people from the States and Canada that are taking it currently. So as part of the 4 years, we have to do 2 years in one of those STARS, which are the local departments or regional departments of public health. 2 years must be spent there, and the work there is mainly there is some health protection, so kind of infection, outbreak control, and those following up notifiable diseases. But then what the other work that you do is very dependent on who your trainer is and what your department is involved in. And it can be some policy work or some advocacy work, it can be anything. And we have to spend at least 2 years training in those. There's no hospital work. A lot of you have spoken about clinical work. We don't need to see it. And we talk to them all the time. But we don't do any clinical work. We're not affiliated to each of them have a couple of hospitals that would be in their region. So if there are problems with those hospitals, we can work with them, but it's not clinical based. And then after those 2 years, we've got a few places where we can go and work. Eve, the Irish Transplant, who is currently working in intelligence units, so they do a lot of work with data and very interesting. The health protection surveillance unit is our focal point for the WHO, so they will be all kind of immunology, health protection work. The immunization office, cancer control program, and there was a rumor that we have to spend 6 months in the Department of Health compulsory. We're not really sure, but all of us do go there, and we obviously get involved in all this mechanism. So these are kind of the ones that we can rotate through, and then there's a few that we're trying to get reinstated that used to be available or that we really want to go work in. So a lot of us who have interest in doing 6 months of academic research placements. We used to do of our trainings back in the day around the WHO, so we're trying really hard to get that over the line again. And then there's our health information advisor, our disease standards in clinical settings, but also with that health and health assessment. What is good about our training scheme is that we do have somebody weighing in what if we want to work with something. So when I was working in my department, I was allowed to work for 3 days a week on the last one. I learned more about how to manage assessment. So you kind of evaluate the agency, you're going to So yeah, that's pretty much it. And for you, any questions? Yeah. No questions?
I think we have solved some problems with the systems from Tanai, also from Ireland, and in her experience in the CDC. An internship she did.
So hi, I'm Louise from Ireland. So I think the program that sometimes gives opportunities to be I'm not going to describe my own experience kind of different. And so I actually did this before I started my program. They let me into my program. And so it was back in 2012, and I'm sure it has changed a lot since I was there. So ECDC is based in Stockholm, and it started here in I haven't heard of one session. So, like all other EU institutions, they offer traineeship programs. And so they changed their application process. So I think once a year that you can send in an application, and then like that's the address where the details on it. And so I think it's all going to be on effectively people. So this is the management is very easy. And the way that includes concurrent and so their organizational structure has changed since I was there, but this is their current one. And so they have a number of units and sections within those units. And so I think for traineeships how it works, so if a particular section has a project that they want help on, and they'll speak to their training department, and they'll go through the applications that they receive that pick a trainee to work with them. So you're usually taking on as a trainee to work on a very specific project. And when I got after my traineeship, it was to work in a group that is actually not there anymore, that is off preparedness. But in a way, the projects I was meant to work on kind of fell apart, so they didn't happen. So it was actually good because then I got to work in a range of different units. So when I was there, I worked mainly within the intelligence team, and I did a little bit with the influenza team, and I did a little bit with the emergency contact one team. So the main project I worked on, I also did a little bit of our original group, the group. One of the projects we did, we were trying to improve collaboration between necessary units across the world, and so we arranged some meetings with representatives from all the different intensive care associations across Europe, to discuss how collaboration communicate better, and say for after the check in Germany, that first came to like 3 intensive care units, so the way that intensive care units communicate to the chat across the outbreak. And with the epidemic intelligence team, so they operate this 24-hour duty system where they do constant surveillance for possible threats. And so it's mainly they have these systems where they can monitor all the media across the world to pick up words related to infectious diseases, and then you have to assess them all and validate them if necessary, and determine if they are a possible threat to your premises and respond to users. And the other thing is, so you basically screen all these different sources. Some of them are unofficial, and then there's official sources, and then you validate them and analyze them, there's constant that, and then every day they have this weekly, or sorry, this daily roundtable meeting where, all the experts gather and discuss the like, so the other thing I did with the academic team was website surveillance, and so under EU regulation, where somebody has recently been in an area where that's not really have to be really public information service, and to facilitate that we did use the website surveillance. I had to look through the website, so most European countries where the possibility of there being website determinants in reporting that are cases, and then that we do that and then we also did a risk assessment too about the when people assess what their risks of having customer cases are and how we should assess it and what and so also when I was there, the most interesting thing that happened was the MERS really first came to life, so then we called this novel coronavirus. And so that was really interesting for me because I got to see the initial stages of that, so how they met it, so what CDC and come up with the initial case information. And from the ITA to see how it all evolved, interesting. And then I did a little bit of work with the team, so this is 2012, so there's been lots of evaluations of the response to the 2009 pandemic. So we went through all the different evaluations that we done and extracted different lessons learned, compiled them, and help the EU member states in developing their updated pandemic preparedness plans. So what did I learn when I was there? And so it was my first ever public health job after doing my master's in public health, so it was a good experience, and I got a lot of scientific knowledge that I'd never heard of before I being there, and I got to and it's some experience with international health and some exposure to how EU agencies work and EU regulations, and some again it was my first time working in a non-governmental organization. The whole new experience, and you kind of learn how organizations work and so I suppose what I recommend to other people, and I think it was a pretty good experience, and I think probably if Euronet members are going, there'll be more experience than I was when I first started, and so I think it's probably just important to consider the work plan they're often using for negotiations to make sure it's easy maybe the time I was happy to learn how didn't know anything. So just in order to apply, you have to be an international. They do have percentage numbers, they're not international, and you have to speak English, and they have other eligibility criteria in terms of your qualifications and your membership with other systems. You can't have done any other traineeships with other EU institutions. And they have one call for applications every year, and they do provide a training grant. So other options that they do offer are they also offer internships, these different traineeships, and that is not a formal way of arranging them. So I think some of them it's because maybe your professor had a link with somebody that works there and they arrange placements that way, and they're not paid. They also offer the education fellowship, people are aware. And I think they're also doing a lot more now on public health training within Europe and trying to support it. And so they have a new virtual training environment. And so at the minute they only have one course starting in January on abstract writing. But I presume in the future they will add more courses to this that we can all do if we want to. And they said they're looking into more the competencies across Europe and how they can strengthen it so that might benefit all of our training programs in the future. And I think they do have links with
software. And they also have this wiki program. I only have it looked at it just briefly, but they have certain. They use it a lot for their essay programs. They have some of their materials that they use for essay. So also Stockholm is a so we were talking yesterday about the internship. Possibly outside of their formal traineeship training.
Do you know how many interns there are, or trainee interns or fellows at this city?
So the fellowship system is different. They're not all paid to use. I think that changes every year. And traineeships, I think it varies depending on what stage. And then internships are very, very different. Being able to contact. I think it can be between 3 and 6 months. No, so there's one application process per year, and you may not hear from them at all, or you may not hear. You may. Yeah, I don't know. I think that they rang me maybe 3 months beforehand, but yeah, they don't have a formal starting point. It depends on what comes up. Not, yeah, not with this system. If we apply through this normal system, we'll possibly create a different traineeship. Yeah, then we may be able to say, okay, I need to lie. Exactly. So that's one, and after that we will discuss a bit of these issues of training process. To be Martin, a former public health resident here in Barcelona. Now he's doing his PhD. And he had the opportunity of going to Johns Hopkins University school in Baltimore. He will tell us about experience there and Baltimore and why.
Thank you so much for the invitation to the Euronet group. Can you explain about my experience at the Johns Hopkins University and the Windows School of Public Health? I am going to speak about the access terms and adherence needed to access to the United States system, about my experience, and also about the benefits I think. First of all, I would like to speak about the different processes you can do to access to the system. First of all, you can access by the preventive medicine and residency program, but you need to access using the USMLE exam. Maybe it's too much complicated, it's why I decided to do another way to access. But this it could be an option. Second, in my case, I decided to do an external rotation and a temporary visitor state. And I decided to do a you can decide to do a research area of interest, and then you have to looking for different active projects in the institution. And the most important thing you need is to looking for a mentor to follow all the process you are doing. There are 10 departments at the institution. I was involved in the health behavior and social department. And about the mentorship is the web page you can use. You can look for different active projects, and you also can look for the faculty name in the different departments. About the other way to access the system is by a PhD program, by a mentorship person, and also a Fulbright scholarship is another way to access to the system. And what you need also after being accepted in the institution, you need yes, it's different documents. You need to access to the system, and the period you need, the paperwork period you need is 5 to 8 months. Okay, I'm going to speak now about my experience. First, I will speak about the future study, and then talk about the problem, in this case, producing the paper. The reason I decided to do this program is because I am very interested in the HIV prevalence and also about the HIV incidence. And in the table you can see in the US, the HIV prevalence has been increasing since 1995 when the retroviral treatment was introduced. The future study is a program which I was participating, and it has financial support by the CDC. Specifically, the CDC has a program that is called National HIV Behavioral Surveillance, and it provides economical support to the insurers. The objective of this program was to measure the HIV prevalence and the incidence, the HIV behavior, the HIV testing behavior, and also measure the use and impact of prevention. The participation, there are 21 cities that they are participating in the program, and also the labor was involved. There are different populations defined as high risk. Is the MSM, the heterosexual group, and the user of the injection drug user. Before each cycle, formative research conducted to learn more about the population and collect data to clarify. There are different rounds that they collect information, they are collecting information, and I was participating in the last round. The financial support to this program, it was $500,000 to this program. It was very different here in Spain that we have this money to that. And the person that are participating in this program in Baltimore, they are students, volunteers. We have also a phlebotomist, a field supervisor, a data manager, a program manager, a principal investigator, and also a principal investigator but in the public health department of medicine. I was contacted by Daniel Berman. He was the person that permitted to me to participate in this program. The material resources, we have a lot of material resources in this program, and also we have vans that we can go around the city to recruit people and do the HIV test, the syphilis test, and also we have another. The recruitment process, in the case specifically for MSN, are sampled using mainly facts. The staff members first identify the venue and days and times. Venue for recruitment that chosen randomly each month. And training interviewers in all programs use a standardized anonymous questionnaire. HIV testing is also offered to all participants and to people, a minimum of 400 to 500 people are eligible to participate in the The way we use to recruit the people is first of all identify the venue. There are different people around the street to recruit the people, for register, have one coordinator, one counter, and one trainer. The recruitment and counting the people around the venue depends absolutely about how many people we have. It's variable depends the place that you are going to recruit the people. And here is like the general population we have, the eligible population in the hills, that is the people that we have to select in the venue, and then get participants. All the participants need to have a consent, and they have to be 18 years old, and they are not, in this moment they are not working. To the interview, we have different questions after interview to where the consent is included, and different questions related to demographic variables, sexual behaviors, across history, drug use history, alcohol and drug treatment, HIV testing behavior, self-conviction, prevention activities, and other variables that are all included in the local survey that are social support, discrimination, and mental health. Here, the scale we use for the discrimination and the evaluation the HIV process we use for the HIV. The counseling, we also do counseling to other people that are participating in the program about being understanding the people, listening to them, and changing some of the things that we are understanding about the and the most important thing, Here, the result, I think, is enough information. And the threat of HIV, the most important thing to say here is the most affected people are MSM black. And the stigma scale, where it's clearly influencing the HIV prevalence. Here is a comparison about MSM, and you can see the HIV prevalence there is 38%, and the specificity in MSM black is 49%. The comparison between MSM in US, in Baltimore and Barcelona, is absolutely different, and the population affected is also different. Here, the different programs we have in Barcelona and in US, and the different funding will be different. And about the limitation in the programs are there, the professional study, self-reported, and the thing is like the CDC has different characteristics in the data, and absolutely influence the comparison between those. And to conclude, the medical change, the HIV prevalence and the infection, there are racial differences between HIV infection that people perceive accounting for demographic and behavioral differences, and unrecognized infection concentrated among younger residents, and also substantial stigma and discrimination experience, particularly in the public population. Indication that stigma is associated with social stress and HIV. Prevention is important in US, the access to the post-care care, drastically for HIV testing and care, especially among young men, and practicing for innovative evidence-based prevention, especially in vulnerable populations. It's necessary for the research standards and best practices. And about the prevention ways to reduce this, I propose different things. Here, the evidence-based prevention that is discussed in the evidence, the experiential evidence, and the contextual evidence. It's creating and the here, the social determinants that are influencing, it's a composing that there are a lot of factors that are influencing, not one, a lot of factors, and we need to understand that the end is how it's the best way to do upgrading intervention. And there are different ways to reduce it using different prevention ways. And an important thing to understand this is continually in the children. There are different campaigns proposed and interventions. And here are recommendations using some ways like regulation to the population and patient population. And to finish, the benefits about the external rotation is that you can establish contact, you can have good collaboration with people about research, international projects, and collaborative projects, about future opportunities involved in another institution, and developing both your knowledge in public health is very important to know different roles in other places. And having the different professional feedback. Also, it provides you a capacity to work in different teams and contexts, and probably you're speaking that in this that can be improved. And all the people that are involved in the program make it better. Thank you very much. Yes. Yes. The mentorship, it's very complicated process really the system because you need a person that is really involved in an active process, and they have money to provide you your external rotation. And the best way is using a person that is really involved in an active project and is even participating in a project that you are interested in. And yeah, if you contact a professor, for example, it's very complicated, but if you contact an assistant teacher, for example, I think that is going to be a easy way to participate.
So you just contact them and say you want to help on their project before you have
Yeah. First of all, I recommend you to see about the active project and then contact the person because sometimes it's complicated. Yeah. If you are interested, for example, in international health, you can look for different active projects there and then contact specifically the person that is leading this project. And then,
You didn't have to do the GRE or anything like that.
Yeah, but it's another way to access. I really don't know how to do it.
So I want to talk to you about your study. I think it's really interesting and all the methods that you use in order to reach all the population. But I would like you to comment, because you showed us governance numbers. Do you think there is a certain selection quantify the stigma? How is that done? Thank you.
Yeah, about the first one question, I am absolutely agree that we have problem because we are using a process to recruit people that can can cannot be real about the real prevalence. But we try to to recruit people in a sampling procedure that it's not affecting the sampling. You know, it's like muestreo aleatorio, random sampler. And we try to do that, but absolutely it's complicated. At the end, the thing that we really want to reduce is the HIV prevalence. And we know that the most affected population are the people that are going to specific places. And we try to see about that. Yeah, first of all, that yeah, we try to, for example, to obtain the people. First of all, we decided at random different places. We would say, okay, this month is going to happen these events, and we decided the places that we have to go. Then, when the people are not participating, about that we can do anything because these people are not participating in the program. Specifically, we work in a specific program that, in a specific place. Yeah, yeah, yeah. We pick them from the people that are in the same. In this moment. Yeah. Mhm. Yeah, is we yeah. For example, I have to say that depending of the population, for example, in Dragon Year, in Executive user, we use first we contact a person and then this person is the way to contact the other person. But in MSM, we exclusively work in a specific venues and we try to recruit people, first of all, communicating them that we are recruiting people to participate. I have to say also that we pay for the participation. The people that are included in this project, they are participating, they are paid for doing the interview. And absolutely we have the problem sometimes that people participating in the program try to do again the same questionnaire because they are paying money to do it. And about the discrimination scale, yeah, we use here using this scale, the people respond about the 10 questions are in the website and they are related to the race, ethnicity, and sexual orientation and the HIV state. And are these 10 questions and the possible response option are yes or no. And then it's like a general classification that is general discrimination, and then this 10 question is divided in three discrimination possibilities: interpersonal discrimination, institutional discrimination, and fear. And the questions are closed then and you obtain the different possibilities.
Just, just another question about the best methodology in this diagram with contextual, experiential, and literature-based evidence. How do you differ contextual from experiential?
Yeah, contextual.
Experiential. Um, Yes, this you can go back to the slide. Like that. Uh, it's, later. Doesn't want to interrupt. Uh, yeah. Um, how do you differentiate experiential evidence from contextual evidence? Okay.
Yeah, sorry. About the experience evidence is about the how do you how your team are planning the way to it's about how experience have your team.
Mhm.
And the contextual evidence is after doing the, for example, first wave, what information, what's the information you have, and it provides you the best way to understand
Okay.
the funding you need, the the thinking you need to have, and absolutely the coordination with relevant stakeholders.
Thank
That two more practical questions about the internship in the Hopkins University. But one is, if you were there, if you know or can you recommend some more interesting areas or some more willing professionals for training? So maybe that's in social science or other areas that are very interesting, other departments of the faculty. And the second one is if you are still in touch with them and you have the possibility after that collaborating. So,
Yeah. About the first question, I think it depends of the interest of the person, but I think most uh, the most active departments are epidemiology, international health, and health behavior and society. And then you can decide what's the active projects are in the institution and decide what you can do. And yeah, continuing collaboration with them because we begin different articles and yeah, and then continuing collaboration. I think it's a good thing when you go to an institution and you are really interested in a program and you can continue to work for free. So,
What about your job?
I was recruiting people also, and I am analyzing data. Yeah. Yeah. During the program, we are going also to the venue, and I yeah, you do the test, give the information to the people, and then yeah, analyzing the data about what's happening. I was very focused on two papers that I was very interested. Really, it was discrimination one, and the other one is about the HIV trends in the US, and we included the four ways to see what's happening around the 3 months to understand if the behaviors are changing and what's happening because the trend is going on.
so we have still half an hour, more or less. So if you want, we can just search and make a round table about all these topics, round table the topics of discussion here, and you can just maybe it's a good idea to talk about the future scientific meetings, what do you think about scientific content? Because I've seen that you were so interested in the scientific part of this last presentation, or maybe we can do the future meetings with a more scientific, specific political content, so try to invite more political professionals, and we can just discuss some of the so,
Put this here so everybody can talk. Hi everybody, hi mom. It's okay if everybody is seated like here. Okay, so everybody has, for example, who have like an idea to continue with this kind of presentation? What you like, what you don't like? Anka or Presley?
Thank you. It's definitely a project that we would like to take and to look more into. We've been discussing like for years now, or even more, about doing a public health European Congress for medical residents. So it's something we really want to do. We really think Euronet should do something like this. But it's very difficult on an organizational level and especially on a financial level. So this would be the big problem. Also, we have to really think about the concept. So we've this addressed to only medical residents, other public health professionals. It should be really, it's the subject for a working group. It's definitely something we should do. So we've been talking about this, but we never managed to concretize this idea. But definitely at this meeting too, there is a need for a scientific congress for mental residents. Because our professors, they all have their congresses. So there is a general European Public Health Congress. There are congresses on hygiene. There are congresses on policy. But we as medical residents, we don't have a congress dedicated to us. So yeah, that's definitely something for the future.
I think it's we were talking yesterday about doing like a video to explain public health. So I think it would be good at least so the benefits always looking to like not have a session where we present a short thing, an interesting thing that we've all worked on, but if we each work on each work, two from each country of a research piece that we presented or we work with. And that way we learn about what's going on in public health in countries and the different types of environments. And I think, I don't know, but like, I don't think we have to keep saying the training and public health is done. I think we have a video now. And like, I think it'd be really interesting to find out interesting things that you're all working on every day.
reported.
Yeah. Like, I will make projects now, like, from social media, in Harvard, and use that system, different places, basically, yes, it can be like Spain, and Croatia. Okay, you don't believe again, it is focused.
Very controversial.
Yeah, and that's translate the language, but yeah, why not? So it's nice to put information on opening WhatsApp and talking to you and somebody else.
There's some things or issues we want to raise important here now, but we had a discussion also in Croatia about, we've heard about peer-to-peer education and discussing something similar about public health residence, bringing closer the public health of the career first to make it good. So we see it as really, yeah, it's unpopular. People don't really know what to expect. And, I mean, in the end, it brings a negative selection to who we are going to work with in the future. So it also might be our interest or duty to educate students in what we are doing. So this was an idea for a working group.
Thanks, Amir. That's great. Actually, last night we talked during the working group future of public health. We discussed about doing an intervention or videos for medical students, and I had a meeting with some people from EMSA, the University of Education, and they were really delighted to collaborate with us. So it's something we definitely should do, like advocacy for public health, making public health sexy for medical students. Definitely. Yeah. Thanks for that comment.
We have nice ideas to start working groups, to start, for example, the video ideas. So every country can make a video about how's the public health training in every country, or it sounds like communication rules, right? The photo, social media, training when you start the residency. I want to talk about also. I want to talk about also. I want to talk about also the training program that Madrid staff is organized by Alex. And this was supposed to start in Barcelona this year, but there was some problems because they only have one training unit and we have five in Barcelona. We're less than them. They are like 17, right? And we're only 7 this year. So it's a little bit difficult to understand that it's difficult to organize 7 people than 17. But it's difficult because we have 5 units to coordinate. We have 5 chiefs to talk to them and tell them that we need a unit of the residents so they can receive about a little things about every hospital and what we public health can do. But that was like a problem. And so I wanted to start this training program this year. Maybe next year we're gonna start it, but it's another discussion for okay. You want to say something else? Yeah. Very nice.
I was just thinking, all of these ideas are very interesting, and I was thinking it would be possible, as I said, to, I don't know if you create a working group on that, but to talk about or think about how we can do as European residents peer-to-peer training at in Madrid. I don't know if in which format, but maybe some resources online resources, or maybe some think about workshop um, in one specific area. Maybe someone here is very he has a lot of knowledge in I don't know informatics or whatever. And we can think about doing workshops or adding workshops to Euronet meetings.
Blanca, and then she said she was trying to say something.
Okay, so I'd like to comment on that. For our strategy for the future, we've discussed also about doing workshops or webinars and on different hard skills of public health, so epidemiology, biostatistics, informatics, but also doing workshops on soft skills because this is something we really need to use in our future career, like leadership, like project management, how do you make a budget, time management also, because we have to learn to spend our time wisely. So yeah, it's definitely something we have to do next years. So there are two different things, hard skills, and in doing this, we can also access our professors. If we do it online, we can ask them to do a short presentation, like 10 minutes, of like a pitch presentation of a certain field, and that would be easier to diffuse the information to all public health residents. And for the soft skills, there are training programs also. So maybe we could have a trainer at each meeting, so we could have half a day training on soft skills. So we'll be discussing about that also with them. Yeah, and
Yes, and organizing with other persons work well as added plus that we create training and we want to it's kind of difficult to make it sexy. So I want to and we do kind of workshops also like for the where meet the rush hours in the street. I like it. Cool, enjoy it. Cool, enjoy it. So it's about international connection, Euronet, why it's important. So, yeah, something like that. So I don't know if someone is interested in doing a workshop. It's going to be around March, somewhere in Holland. Contact me. Okay, thank you very much for looking at. Yeah, like a kickoff to get started. And people asked me yesterday, when are you coming to Barcelona? Like, why are you running away from your new trip in Holland? And I said, yeah, I have to go. I have to work in Barcelona. I have to know what are you talking about? So I think it's nice to introduce this Euronet in Holland and the other things. So they have much to do. Yeah. Hmm? Yeah.
Should be one about the things that was covered by income. It would be interesting about what I mean, we can teach communication videos about certain topics, but then we will need to think about like I don't think that all professors can do teaching English just yeah, that this is really interesting.
Actually, you could do it.
Hmm?
Like, you
Yeah,
put a subtitle only with what they listen.
yeah,
Yeah, you
but
could do it.
that works.
Yeah, it works.
Sometimes.
Like, but if you have maybe also, for example, here in Spain, I have the mic here. So
Okay.
here in Spain, it's a little bit difficult for every resident to talk in English, but I think that all of them have like some idea, right? So with subtitles,
No, but that would I believe that subtitle but then it's a thing that is taking develop, and also the presentation I wrote today, I didn't do I wrote it because I found it interesting that one of the objectives of the Euronet is to develop a core competencies approach to public health among European public health residents. So that is a suggestion also for next year activity to think about revising what when this for competency framework will be established in this for competency framework and about maybe we could help us decide. I don't know if it's overall, but yeah, but part of the reason for here is that as soon as I started my university, I started working with English co-funded projects at my institution in America. There was a project more like skill implementing international projects. Might be a great topic for the network to maybe present with working on work. And in the future, we will develop a platform, a way to find project partners. So this is sort of my view and idea. So we can see how we incorporate this digital transformation there, European Commission projects, corporation to Europe. A lot of things.
It seems that your contact would be a good entry point. Do we have any more comments on our ideas for future partnerships, future public health, how we could get involved more? So, just to resume, public health congress for young professionals, because of course we're going to we're going to include non-medical residents. It's a logical thing to do. Young. Okay. No, I'm sorry, I was discriminating without even noticing it. So. Yeah, young is less than 60.
But some of our have said that they feel that they feel like we're watching.
Okay,
They
so
don't want to come.
not at all. We like okay. Being serious a little bit. So let's say a congress for public health. Yeah, but I think they won't identify with junior either. So I would say, exactly. I would say public health trainees. Yeah, 60 years young. So the idea of the congress, workshops on hard skills done by either by residents that are really good in a certain field, either by professors that are experts in their fieldwork with subtitles from their native language, so English subtitles if they don't feel comfortable talking in English, and also subtitles if they're talking in English and your residents, maybe their residents don't understand very well. Subtitles in the national language, but that's up to every national team to do that. Workshops on soft skills, workshops and training on soft skills, and afterwards peer-to-peer information, peer-to-peer training or a sort of collaboration between European residents, European residents, because I think it's really interesting what's happening in Madrid. Like you're trying to formalize something for residents that don't yes, that don't have a
Of the
formal.
residency or is that what else do you think?
Yeah, yeah, I think that's the case in most European countries. So maybe peer-to-peer, a sort of I don't know, making like deciding for every new resident a sort of bigger brother or something like that, a sort of mentorship, but inside the association. So these are just ideas, and we're resuming what we talked about. So definitely a good idea from us to for the workshop next year. Yeah, we're going to discuss more about that. Yeah, so I'm gonna pass the mic to Petra.
Yeah, sure, this is great. Bit slow, sorry. I just thought of something else. Because I don't know if how relevant this in other countries, because I think our virtual education is a lot different from what I hear here. But what's going on in Norway now is that there's a think tank um, that thinks about how what healthcare should look like in 10 years or in 20 years. And it's composed of public health residents, but also medical residents, and GP residents, and pharmacy residents. So also maybe as a team that's the collaboration with public health residents across Europe and medical students, but also other doctors, because I see a lot of other doctors don't even know what I'm doing. That's kind of the case. Oh, I didn't know you existed. Yeah, one of the Lascio members is the president of think tank. Maybe that's what he was saying.
Yeah, I think this goes with the idea that we had yesterday and what Jamia commented on. Uh, Medical students, they don't really know what public health is, and they're not really attracted by this specialty. So maybe if we do this for the general public, also for medical students, like telling saying what public health is, there's a very, very interesting video created by the French National Association with that's called what the public health doctor. So what does the public health doctor do? And it's very funny. Maybe we could adapt it, we could transform it to brand it with Euronet and send it to Euronet.
Thanks everybody for participating. Thanks to people who talked here. And well, this is it. You're going to eat. Right. Everybody could say goodbye to the streaming so we can stop it. Or you can say